Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Lisa Stromquist, and I'm your host for the next hour. So Spark Live is where we gather each Wednesday to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community, with our goal to spark conversation, ideas, innovation, and action. Since we're live, I want to remind everyone you have the opportunity to type questions into the question box at any time, and we'll check for questions throughout the session, so please don't feel you need to wait until the end of the presentation before you start typing in some questions or comments. Although we have been working from home without our regular setup for a while now, we would all still really appreciate your patience if we run into any technical issues. We did get a little bit of a late start this morning because of the technology, so appreciate all of your patience. We also, throughout the presentations, encourage you to share your thoughts on Twitter, and be sure to tag us at Child Health Can. And also, just a little reminder of the 2020 Children's Healthcare Canada Conference, Building Bridges on the Road to Healthcare Equity, is taking place virtually November 16th to 20th. Registration will be going live very soon, and we have a really exciting lineup of speakers to lead us through conference week. We'll weave a thread through themes of healthcare integration, inclusion, virtual care, how COVID changed health services, and much more, all heading in to how we reach healthcare equity for Canada's children and youth. So today I'm really excited about our webinar. This is the third in a series of sessions on children with neurodevelopmental disorders. And so far we've learned about identifying comorbid psychiatric conditions and aggression in children with autism and related neurodevelopmental disorders. Today we're going to focus on your case stories, and we've asked families to submit their stories and questions so our panelists can address real-life situations. So it's my pleasure right now to hand the mic over to Dr. Jennifer Russell. She's a child and adolescent psychiatrist and clinical director of the COMPASS program at BC Children's Hospital. And Jen's going to introduce the rest of our panel. Over to you, Jen.
Good morning. Thank you so much, Lisa. I just want to make sure I'm able to share my screen. Oh, here it goes. Can people see the presentation?
Yes.
Okay, because I can't see the presentation. Am I probably doing something wrong? Okay, so I wanted to thank Lisa. Thank you so much for that warm introduction. My name is Dr. Jennifer Russell, and as Lisa said, I'm a child and adolescent psychiatrist that works at the COMPASS program at BC Children's Hospital. And I'm delighted today to introduce three colleagues of ours from the neuropsychiatry clinic here at BC Children's Hospital. Today we have Dr. Ainsley Boudreau, who's a clinical psychologist in both the neuropsychiatry and OCD programs here at Children's. Dr. Robin Freelander, who's joined me for the last two webinars, who's the clinic head of the neuropsychiatry program here at BC Children's Hospital. And Trudy Pisha, who's a parent with lived experience. As Lisa mentioned, today's talk is going to be a little bit different than previous, as we're going to be responding to questions from, I'll call it the crowd, people who have attended the last two seminars, but please feel free to send in more questions as we go, and we'll do our best to answer them. So just starting off, we have no disclosures or receiving any financial funding for this. Just to give people background, this is the third in a series of 3. And all these presentations are going to be on the web, and Lisa's going to be sharing in the chat function the actual link where you can click to access the previous 2 seminars. There was one slide in particular that had the algorithm of managing aggression in autism, and that has been specifically placed on to make it easy for people to print out. And I just wanted to remind people that this is still in draft form, so just use it within that context. So session 1, we went through Autism Plus and an approach to comorbid psychiatric presentations. The second session focused on managing aggression, and this third session is on case presentations and reviewing questions. So what are our goals today? Our first goal is to address questions from the crowd. We ended up getting many more questions than cases, so the bulk of the presentation will be responding to these excellent questions from a multidisciplinary perspective. To review a case of psychiatric management, for the people who wrote in the case, I have disguised the case to protect confidentiality. And also learn from a parent about what it's really important for providers to know about these topics. So briefly, why is this important? As everyone here knows, COVID-19 has had a significant impact on all of us, but in particular, youth with neurodevelopmental disorders. Many of them, with the school closures, lost a lot of their respite support and specialized services, leaving families to cope with extremely challenging situations, sometimes in isolation and without the support normally provided outside of a pandemic. And so today we want to review these cases and what we can do to support. This is the slide, and I'm just bringing this up again for the aggression algorithm, and it's going to be posted, and we're going to reference it again throughout the talk. Okay, so the first question that we got, and this is a really excellent question, what is parent training as opposed to parent education? And Ainsley, I'll let you take the lead on this one.
Sure, I think this is a great question to kick us off because you'll often see so many terms out there. And one thing we know for sure when working with youth with autism is that we are always wanting to involve the parents because generalization is such an important skill. And without explicitly teaching skills and explicitly teaching generalization, we know the skills won't often transfer. So having parents involved is essential. When it comes to parent education, you'll sometimes see this in the literature, parent training versus parent education, but it also applies to kind of real life clinical practice. Parent education is much more of a psychoeducational kind of session where parents will get lots of information about behavior management and autism and that sort of thing, but there's no direct instruction to the parents, whereas parent training involves much more of an explicit direct instruction to the parents. There's often videos and vignettes, practice activities, role plays. As much as people hate role plays, they're super important when thinking about working with kids with autism and the various scenarios. Homework assignments to make sure that parents are practicing the skills and they really get hands-on experience, and then having the psychologist or therapist work through them with that. And it helps parents develop a skill set. So it's not just a therapist or a psychologist who has all the knowledge. The parents learn how to identify the function of a behavior and develop and implement strategies.
So Ainsley, what resources are available for families and clinicians that want to learn more about this?
Yeah, so I think if you just scroll to the next slide, I have one example here that I've used quite a bit and has received some good research as well. So there is a manual by Karen Bears and colleagues, and they have done some clinical trials, some randomized control trials. and they looked explicitly. Oh, here we go. So this is the manual. I have them sitting in my office, Parent Training for Disruptive Behaviors. There's both a parent manual and a therapist manual, and they have really nice handout sheets. You can kind of follow along. It really aims to, again, break down, helping to understand the function of a behavior, what the behavior actually is, what are the consequences that happen afterwards, and how to develop both prevention and consequence-based strategies. So I quite like this manual, and there's been some good randomized control trials done on it. And usually this would take between 11 and 13 sessions for about 60 to 90 minutes. And what we find clinically and in the research is that there's lower disruptive behaviors, more daily living skills. Caregivers feel much more of a sense of competence in how to handle their children's behavior. So this is one that I tend to like, but there are others.
Excellent. Now, one question, Ainsley, we got a lot was, how can we help children and youth with neurodevelopmental disorders learn to manage their emotions? This seemed to be a really hot topic.
Yeah, so I can start, and then I'll pass it over to Trudy. But I think this is a really hot topic, and you'll see this question come up from an OT perspective. You'll see it come up in the psychology lens. You'll see it come up in with SLP. And I think the most important thing is to not skip over this question and to know that even if emotions are harder sometimes to develop that skill to recognize both in themselves and others, that it is teachable. And I think that's a big theme across all of the work that I do with a lot of the youth with autism, is that just because something doesn't come as naturally to these kids does not mean they can't learn it without explicit instruction. And so I think of teaching emotions just like any other skill that you would have to teach a child, like riding a bike or putting on their coat when they're young. So something really simple I start with families and with kids is just starting with the idea of name an emotion to tame it. So sometimes just the identification of the emotion itself brings down the anxiety level. But before you even can name an emotion, you have to work with kids on what are all the emotions? What are the emotion names? Sometimes I like to use emojis for kids because they're really fun, and everyone uses emojis now. And that's a good way to start with some buy-in. And I start with the most basic, happy, mad, sad, that kind of thing. And so we start there. And then I always encourage parents to model emotion words themselves. We as adults are not the greatest. If you look at our language day to day, we are not always the greatest at just saying, hey, I'm mad. Or, yeah, your mom's feeling frustrated right now because she let the water boil over on the stove. And so starting to explicitly use those emotion words for your child. And then just like any other skill, so this may not be fun or easy for these kids, and it often isn't. So making sure we attach rewards to the use of emotion words. And I like to use rewards when you catch a child doing something good. It's not necessarily something they have to do, but they get bonus rewards and something they're really interested in if you catch them using those words. So those are some ways that I like to work with emotions. And then this is, many of you have probably seen this before, but having a traffic light system to teach emotions works really well. It's really visual. It's not overly complicated. So you either have green zone, yellow zone, or red zone. And so for kids who maybe struggle to pull up the emotion word in the moment, because it can be really hard to access the words for a lot of these kids, some kids just and parents go to a system of, I'm feeling in the red zone, I'm feeling in the yellow zone, I'm feeling in the green zone. So red would be really mad. I like to sometimes, depending on the developmental level of the kiddo, you can start to attach what kind of behaviors are attached with red zone emotions, like in this case, punching the wall or cursing. Yellow light emotions and cues, so things that both parents and kids can start to notice, oh, hey, whenever I start to tell myself in my mind how unfair this is, or whenever my voice starts to get louder, that's a cue to my mom and my dad and I and myself that I'm in the yellow zone. And maybe there's some strategies I can use in the yellow zone. Or green, I'm feeling okay.
But those are some really helpful techniques. Trudy, I'm wondering from your perspective, what have you found helpful?
A lot of that has been important for us, particularly when my son was younger. And as we went along, helping him, he had giving him storybooks. So one of the ones we used was On's Anger, and the story is about a child who has to learn to sit with his anger. And then for myself, there was a couple of books that I read and I've used a lot. The Whole Brain Child and Self-Regulation. Self-Reg by Stuart Shanker's one that I used a lot and I've recommended to other people. We used a lot of board games, both in and out of therapy, and I also shared them with his teachers at school. So there's a series of Go Fish card games that talk about conflict or self-esteem or anger management. And there's all kinds of different ones out there, but those were really helpful for him. And also just the family, like my daughter and myself, in working with him. When I talk to him, I try and put things into context. So like asking him if something was a mountain or a molehill, right? To help him understand it wasn't as big maybe as he thought. And when he started to be able to answer back, like, no, it's really not that big a deal, right? So it was a molehill. And then I started to look on the web for different kinds of resources that we could use as a family to try and help, whether it was, you have to be careful on the web, obviously, but there are different therapy resources out there. There's different school resources like understood.com. There's all kinds of things out there. You can find other parent groups and stuff like that that can help give you tips and whatever for working with your kid.
Thank you. Like, one of the clinical pearls in talking with the three of you this week has been really holding the notion that this can be learned and can get better. And so people can sometimes forget that, like in the moment, but this is really a skill, just as Ainsley said, like riding a bike, that can be taught. Okay, another question from the crowd. And Ainsley, this one's headed your way. We talked a lot the last 2 weeks about providing evidence-based therapy, specifically for children and youth who have anxiety or mood disorders in addition to their autism. Can you provide CBT to children who are nonverbal or don't communicate? What's the thought on this?
Yeah, so I think this is a great question. And so cognitive behavioral therapy is originally designed for kids who are verbal and communicate. Now, it doesn't mean that the child needs to have very sophisticated language, but ideally there is some language there, an ability to communicate. And that is paired with a therapist or a psychologist who also understands that you need to tailor your CBT for that child's language level, for their understanding level, receptive language level, and their overall intelligence level. So that part's really important in concert. So kids who are completely nonverbal or minimally verbal, what the research evidence would suggest, as well as my clinical experience, is that they are much more likely to benefit from a more behavioral approach, heavy on the B side of things, and also heavy parent involvement and direct instruction to parents. So much more of an applied behavioral analysis lens and a behavioral, like a positive behavioral support lens to support those kids is what shows to be the most effective. Having said that, it's really important to understand that CBT is evidence-based and can be adapted for kids with autism who have an intellectual disability. I do CBT all the time that's adapted for kids with autism and intellectual disability. And I just changed. So instead of talking about instead of using the word cognitive distortion, which I might use with maybe my 17-year-old teen without autism, I might talk about what are your active mind thoughts, or what are your helpful thoughts, or what are your not helpful thoughts. And I may use their special interests, which is something that's really important, to use analogies. So I use Captain Underpants a lot when I'm doing my CBT with kids on the spectrum, for example. So I think it's important that as a parent and as a clinician, you're advocating for making sure your child still gets the evidence-based treatment for your child, if there is anxiety there, if there is mood, if there is challenges that way.
Excellent. I got to hear those Captain Underpants analogies because he's a very popular person in my house too. Okay, next question that came up is specifically about autism in young girls. Does it present differently? Are there things, are girls not being diagnosed? Ainsley, what are your thoughts on this?
Yeah, this is one of my favorite topics because I think historically, and still I think, girls are way more often missed. So I think for a while, I think historically we thought there's just way more boys in autism, and that's certainly what the data would suggest. But I wonder if we're just not really picking up the girls as much. And the DSM, we just don't have enough research, and so perhaps even some of the diagnostic terms that we have in the DSM are not necessarily capturing how this looks in girls. And what I have found with girls is that they are much more likely to be picked up in their teen years, because that's when the social demands start to get really hard. And so it's not that the social differences weren't there earlier, it's just that girls, in my experience, have been much more sophisticated in some ways at kind of hiding it or masking it. So these are the kids, when I've done the autism assessments early on in the preschool period, where I start to watch them play, and they're doing a pretty good job with their dolls and kind of talking back and forth, and it kind of looks pretty good. But then you watch them over time, and the play is the same script over and over and over again. And if I tried to join the play with dolls, they were very rigid and wouldn't let me join in. So those are some of the more subtlety things. So I think these girls tend to be labeled as sort of maybe socially interested, so they're kind of watching, but a bit odd, and they don't quite know how to always fit in. Maybe they're watching from the sidelines. Maybe they're not overly externalizing or aggressive, but over time we really see much more anxiety happening. So I think it's something to really keep an eye out for. And this is a book that I have really enjoyed. There's not as much literature out on girls. There's a lot more online, but parents I've worked with and have really found this helpful, called Girls Growing Up on the Spectrum, with Shannon Nichols, who spent a lot of her career dedicated to girls on the spectrum.
Thank you. Now, we were talking earlier about parents' education and psychoeducation, but we've also been talking about parent-child interaction training. Can you help us understand what this is and what it's good for?
Yeah, absolutely. So PCIT, it's not originally developed for autism. So this is a evidence-based parent coaching intervention. It's manualized. It's typically done for kids under the age of 7, preschoolers who have disruptive behaviors. And it's actually a really, I love this intervention. I was trained a little bit on this intervention back in Nova Scotia, actually, where I used to live. And it really focuses on improving parent-child interaction and reducing behavior problems. But it's cool because it's done real-time parent coaching. So the parent comes into the office, they go behind a one-way mirror with their child and some toys, and then there's the therapist or the psychologist behind the mirror, and there's a bug in the ear. So I would actually, or whoever the therapist is, actually coaching the parents through a series of skills. And it really breaks down behavior and interaction in a really data-driven way. And so the first part of the intervention is focused on the interaction and improving the interaction between the parents and helping them play and just comment. And then the second part is focused on the more behavior management strategies. And I actually had to look this up as to where the research was on this topic and is this effective in autism for this question. And I did find at least 3 randomized control trials, which is sort of the gold standard of what we look for. And there definitely shows promise. So definitely decreases in disruptive behavior. And the most recent trial has been in 2019. They compared PCIT to a waitlist control, and disruptive behaviors decreased, parent skills increased, and there's no change in parenting stress, although we know that parents who have kids with autism are stressed all the time for lots of reasons. So it's not uncommon for us to not see changes in parent stress level. I see Trudy smiling at that one.
Trudy, did you have anything you want to add to that?
No, I'm good.
Okay, so moving to a slightly different topic, we spoke a lot about OCD as one of the possible comorbid psychiatric disorders in autism. And we talked about exposure and response prevention as a treatment. Ainsley, can you help us understand, like, what is ERP? Tell us what's really going on.
Sounds good. So ERP stands for exposure and response prevention. It basically means facing the thing you're afraid of or the thing that makes you uncomfortable without engaging in the compulsion, the ritual, the safety behavior. And in some cases, the thing that people do is avoid stuff. So in some cases, it's facing your fear without running away. And ERP can really be broken down into this. So what happens typically is there's an obsession. So let's say the obsession for a particular child I'm working with is, I'm really afraid I'm going to get cancer from touching a doorknob. And by the way, obsessions in autism sometimes look quirkier. So if you notice that the child's obsessions sound odd, I wouldn't get too freaked out by that, because we notice the thinking in autism is different. It's neurodivergent. So if the obsessions seem a bit more odd, it's still part of OCD. So an obsession comes up, let's say, I'm worried about getting cancer from touching a doorknob, even though you logically know that's not the case. A child's anxiety spikes. Then what typically happens is they engage in some kind of compulsion. So maybe they touch the doorknob, but then they wash their hands for 10 minutes afterwards, or maybe they avoid touching it altogether. And in the short term, they're relieved. But in the long term, there's this negative reinforcement cycle happening where they think that because they didn't touch the doorknob, that's the reason why they didn't get cancer. And so the whole point of ERP is the X, where you see the X on this graph is essentially what ERP is. You want them to be triggered by the obsession, feel the anxiety and distress, and not engage in the compulsion, ride out the anxiety until their anxiety comes down naturally and learn that they can handle it. So if your child has OCD and autism, be really diligent as a therapist and a parent to make sure you're asking for ERPs, because that is the core ingredient here.
Yeah, that is definitely a clinical pearl. Okay, moving on. We got a number of questions about diagnosing ASD in young school-age children who are verbal and have comorbid ADHD. Robin, did you have any advice on this one?
Yeah, well, good morning, everyone. Yeah, so this is I think I talked in the last couple of talks, if you were there, about how autism and ADHD often have similar symptoms. And this is a little study I just found when I was looking it up this past week. So this is a clinic where school-age children were referred to a clinic to see whether they had an autism diagnosis. And the clinic evaluated them as having ADHD, not autism. Nevertheless, about 21% of these children, so that's like 1 in 5, met autism cutoff on the ADOS, which is the gold standard which is it's a observation of the child, which is what's done in making an autism diagnosis. So 20% of the children who had ADHD nevertheless met the criteria for autism and on this observation interview, and 30% of the kids with ADHD met the autism criteria on the ADI, which is the autism diagnostic interview, which is a interview with the parents, a structured interview with the parents to see if they have autism, if the child has autism. So I think what you can see is that diagnosing autism is not that easy in a child who has ADHD. Often ASD and ADHD co-occur. I think I talked last time that there was a co-occurrence that about 50% of children with autism had ADHD as well. So the bottom line is this is really hard. I think this particular clinic obviously had a lot of clinical experience and made a clinical judgment that these children had ADHD, not autism. But I can tell you there may be another clinic that made an autism diagnosis in these kids, and that does happen.
Okay, now following this up, Robin, everyone wants to know, you mentioned that there's 2 pathognomonic symptoms of autism. What are they, and can you explain them to us?
Right, so I think what I just explained when I was talking in one of the previous talks, I said that most of the symptoms of autism are not distinctive to autism. And in medicine, we say that they're not pathognomonic. If a symptom occurs in other conditions, not just that condition, So the two symptoms that are distinctive of autism and you don't see in other conditions are using the other person's hand as a tool. So you want to go to the fridge and you're going to get your mom to get something off the top shelf because you can't reach. Instead of like looking at your mom, let's say you're nonverbal, instead of looking your mom in the eye or pointing, you just take your mom's hand as if it's a tool, and you just take them to the fridge and you put their hand where you want them to go. And the second pathognomonic symptom is pronominal reversal, where you don't. This is actually true lots of young children have this, but essentially, as the child gets older, they still don't recognize that there's a difference between the words you and I. So instead of using I want to go to the park, they'll say you want to go to the park when they mean themselves. And I think I said here that these particular symptoms you will find on these tools that clinicians use to diagnose autism, called the ADI and the ADOS. And the reason I mention that is because you look at the DSM-5, the criteria for autism are actually, I think, quite overly complex. I'm not sure they've done us as a favor by the new criteria. But actually, clinicians, when they diagnose autism, expert clinicians, they don't use the DSM-5, they use these tools which include these particular symptoms.
Okay, thanks, Robin. So continuing on with diagnostic difficulties, is it difficult to assess autism when a child has already been diagnosed with ADHD and an intellectual disability? Ainsley, what do you think?
Yeah, so just to piggyback what Robin said, so really the gold standard in autism assessment is the ADOS and the ADIR. And the ADOS is a really structured play observation, and there's different modules depending on the language level of the child. So you get to do different kinds of presses to see how they would respond socially. And you can get trained in this. It's a very helpful tool. And the ADIR, like Robin said, is this really sort of long but developmental history that looks specifically for these more social, repetitive behavior, language nuances. So I think having the gold standard measures and having training in this, it is possible for sure to diagnose autism when a child already has ADHD and ID. So I think that's important to note. Again, you're looking at the social, what the social expectations would be for someone who has that developmental level, and that's important. And so it's important to have someone who understands both of those pieces when making the diagnosis. And so often I would hope that there'd be some sort of cognitive assessment along with it if there is a diagnosis of ID. But I will say that sometimes ADHD is overdiagnosed in intellectual disabilities because what will often happen is the child will just not look like they're paying attention, but it's not because they have ADHD, it's because the world around them is talking at a level that's way above their understanding. So of course you're going to look distracted. If someone's talking to me about, PhD level physics, I'm going to look like I have ADHD as well. So I do think that can be overdiagnosed. And then sometimes autism can be overdiagnosed in intellectual disability, which is a whole other kettle of fish. So there should be distinctive social impairments that don't go along with just your general developmental level. But all that to say, they all can be diagnosed together as well.
Okay. Yeah, these are very complex cases, especially when you've got several issues happening at the same time. Now, Robin, further to our talk last week, is medication always necessary in these cases?
So the short answer is no. Medication is not always necessary. Specifically for treating autism, there's no medication that actually treats the core features of autism itself. The use of medications is generally either to treat comorbid psychiatric conditions, which is what we've been talking about in these talks, and then they can be very helpful. And sometimes if there's no clear comorbid psychiatric condition, but the child is extremely irritable and aggressive, and they're not responding to behavioral measures, then sometimes medications can be used to manage irritability. And with all medication decisions, and in fact with any decision at all in medicine, you have to weigh the benefit and the risks. What is the benefit of this particular medication? And how much does that outweigh any particular side effects? And the other point I think that Jennifer Russell was making previously was, what is the risk of not treating the child? So let's say the child has ADHD and you do not treat the child. What is there going to be the impact on this child's relationships with their peers if they're always butting into their conversations, not recognizing social rules, and becoming socially excluded and ostracized?
Now, we've been talking a lot about autism. Robin, what about children and youth with FASD? What are your thoughts about medications with this group?
Yeah, so this is a question that came up at the first talk actually. And we were talking about neurodevelopmental conditions in childhood, including FASD, autism, intellectual disability, and ADHD. And so in general, our approach is that we see the neurodevelopmental disorder. We recognize that there's no medication specifically for treating, in this case, fetal alcohol spectrum disorder. One tries to understand, is the defiance, irritability, and mood swings understandable just related to FASD, or is there a comorbid psychiatric condition that is there in addition to FASD? There are medications that can help with comorbid psychiatric conditions. If the moods are changing rapidly within each day, and there's a lot of defiance and irritability, then I think one has to consider whether the child has ADHD as well, which is, as we know, a very common psychiatric disorder of childhood. If the child has ADHD, consider a stimulant, clonidine, guanfacine, or atomoxetine, which are the medications that are effective in this condition. If the child has anxiety or depression, which can also present as defiance, irritability, and mood swings, then you should consider instead a anti-anxiety, antidepressant medication, which are, and the commonest we use nowadays are called SSRI, serotonin reuptake inhibitors, such as fluoxetine or sertraline.
So, Robin, one thing we hear a lot about today is complementary medications. What's the evidence for that in this population? Is that something you recommend?
So, well, families usually get over-the-counter medications from their pharmacies or naturopaths, and usually when I see kids in our clinic who have autism, I'd say most of them are on at least one over-the-counter medication. Most of them do not have any evidence that they really work. For example, there's one of the kind of supplements that is used is called GABA. And GABA is a really interesting idea because GABA is actually the calming chemical in the brain. So in theory, it sounds like a great drug. And I think it's fairly commonly used in this community and by families. However, GABA doesn't cross into the brain. So although it sounds a good idea, it actually doesn't get into the brain, so it's not going to work. So the three over-the-counter medications that do have evidence that we often use are omega-3 fatty acids. These are helpful for ADHD, generally the inattentive form of ADHD, at a dose of about 1,000 milligrams a day. NAC, which stands for N-acetylcysteine, and this has been used for in autism, for irritability in autism. It's been used in OCD and for children who scratch or pick at their skin at a dose of 900 to 2,700 milligrams a day. And finally, melatonin, which is a hormone that basically tells the brain it's time to go to sleep, at a dose of usually 3 milligrams a day, but one can go up to 15 or even 20 milligrams a day if necessary. There was a question about how long one can give melatonin for, and the answer is indefinitely. It's extremely safe.
Okay. Now, Trudy, we're hearing about all of this stuff, and as you know, these youth are really complicated. How does the parent know what's out there and navigate the system, especially when you're just finding out that there's a problem?
Yeah, that's one of the eternal questions as a parent, right? And it's, you know, at least normally what happens after diagnosis, and we've been in the States and then we were here, is after you're diagnosed, you know, the clinician is the first one who sort of says something to you about what you need to do. In BC, the first thing that happens is you get set up with a social worker from Child and Family Services. And I think that's often what happens across Canada. There may be some deviation. And they sort of help you identify access to resources and funding. So, you know, the province out here has, all the provinces have a website, and they talk about the different programs that exist. School boards for kids who are going into school or who are in school, they have support programs, and so your local school board will be able to tell you what's going to happen when your child with a diagnosis gets into school, and you have to start looking at IEPs and all the rest of that. And all the communities have organizations, right? So there's, out here in BC, there's the Developmental Disabilities Association. They do respite, but they also help with IEPs in the schools. And every community has something like that, right? You might have something like the Pacific Autism Family Network, and they also are out in all the communities. And they do things like help you find, you know, different social networks for your kids. They can have resources around different therapies, whether it's ABA or social therapies. There's also the Family Support Institute out here, which is very good. So you will always be, if you search, you know, autism therapies, you will find different community resources. I think it's also very important that you kind of look to other parents to build a network of what they have found. You can look to Professional Association for Occupational Therapists, for SLPs, for any kind of therapist that you need have professional associations. They're licensed. They'll tell you what they practice, and those are key. But it's hard because there's a question of what's supposed to happen and what really happens. So, for example, with us, when we first met our social worker, perfectly caring, nice person, right? We never heard from her again in 3 years because the provincial social services groups are so backed up with every kind of need known to, you know, man, that they're overwhelmed, right? So the bottom line for families is you have to learn to advocate on behalf of your child, right, and your family. Same thing happens in schools. It's just, it is what it is. You have to be there, right? And if you need something or you have questions, you have to ask. The clinicians are going to have to, you know, they have to help guide and support families, because most families, especially when they're first diagnosed, they're shell-shocked. They have no idea. I've seen so many stories where you've got families and they get told they have this funding, and then they get put on wait lists, and they wait because they're on a wait list. But you can't wait. You have to push, right? Schools are not going to do anything unless you push them, right? So Early intervention is great, but it's not a panacea. A lot of kids don't get caught until they're past the early intervention years, right? Parents don't know what they're looking at. So the other thing I always your kid is going to grow and they're going to change over time. Every time they physically grow, their symptoms are going to change. Their brains are changing, their hormones are changing, and this never goes away, right? You'll have progress in some areas, and then you're going to backslide in other areas. So as your child's needs change and their conditions change, they're going to have different, the manifestations are going to change, and their therapeutic needs are going to change. And the goal is always, always that they need to be given the skills so that they can, make their best way, right? So it's all about skill development, exposure to different things so that they can make choices. How do you get your child into that way, whether it's educational or it's clinical or it's therapeutic? And it's going to be a combination of things. So it's always that advocacy and creating the links and asking the questions.
Now, Trudy, you've walked this walk. What are the clinical pearls that you think providers in Canada and parents need to know to best support these kids as they grow up?
So I think all of you have been very good at pointing out that autism is complex and it's dynamic, right? It's not one thing. That old saying about you meet one person with autism, you've met one person with autism, right? It's a very sort of individual thing. And because it's very complex and it involves, it has different impacts on different systems, those systems in the body interact and they can have domino effects on one another, right? So you need a multidisciplined team. There's not a magic bullet, right? There's no single specialist or therapist or treatment or medicine that's going to fix this. There is no way to fix it, right? Everybody has a part. So whether you're dealing with an educator or you're dealing with a therapist or you're dealing with a specialist or your GP or your family or any support worker, it's a team, right? And everybody has a part to play. So also, the families, whether it's your core or your extended or whatever, everybody, including the child or the person, has a role to play in this. It's critical that everybody is sharing information across that team, right? And I find that as the parent, I'm sort of the kind of connector at the middle of that, or the super connector, if you want to be, because I'm the one who's been the most consistent, right? And because my child is not yet in a position to be that super connector, I have to be the one. So I'm the one carrying, my child is going to be 15. I have 15-ish, because he didn't enter we didn't start, his first diagnosis was when he was 15 months old. So that many years of evaluations and reports and tests, and I've got it all, right? So I'm sharing all of that with the people. At the start of every school year, I introduce the entire team to one another. I give them permission to talk to one another, and I start, right? Every time we see somebody new, out comes the barrage of stuff, yeah? Sometimes I'm an advocate. Sometimes I'm his proxy because he doesn't know how to express. He doesn't recognize, certain physical feelings or emotional feelings or whatever. And I think the other thing is the whole team has to learn to work together to triage what is the priority at whatever time. Because as this thing changes, as the different waves come, you have to sort of decide what's the number one thing we have to address now. And then you peel the onion and you go after something else, because you're always looking for root cause. And, the behavior is ahead of the research. We don't, there's still miles, and as Ainsley said so well, there's miles of research yet to do. We don't know the brain well enough yet. So I think for parents, it's incredibly important to develop a network of people that you can share contacts with, experience with, that you can use to know what's going on. And even though you're dealing with a network of professionals who treat your child, do what you can to support them, right? And use them as part of the network. Fit is important. Sometimes your child doesn't connect, or doesn't, the therapist that you, or the interventionist that you might find, it's incredibly important to try fit. So if that relationship isn't working, you may have to switch it out. And that doesn't mean that the interventionist or the therapist or whoever isn't really excellent at what they do, isn't a great person, but it just might not work for your child, right? And so at that time, it's not always a bad thing to find somebody else. It's okay. Like, forgive yourself and move on.
Mm-hmm.
In some places, you may not be able to do that, so you have to just work together to make it work, right? I mean, it's all about balance. So your therapist can help you find other therapists. They know people, and they know who can work well with your child. Use that. Be careful of the resources you use, especially when you're looking online. There is so much. Years ago when my son was first diagnosed, we were in the States, and people were running around and they were giving their kids B12 shots, and that's all they were doing. Don't. And if talk to the scientists and the doctors about what you're using. Now it's all about TCP. Like, no, right? Please be careful. And if parents need, these are complex behaviors. Like Ainsley said, it's not a picnic. There's a lot of stress in the families. There's a lot of stress on the kids. So, reach out. You got to. So I think the other thing is, what really matters at the end of this is that keep in mind, keep your expectations in line, right? And keep what matters at the heart of it, right? People with autism they can grow up, they can have really high quality lives, right? The important point is that they know that they're loved, that they're going to enjoy their life. They have special interests. They all have gifts. They have value. What they're really good at, or what they really enjoy, can lead them to something that they're, I always say to my kid, I don't care if you're an elevator operator, he loves elevators, he loves cars. There's a million things he can do with that, as long as he's finding something that he's comfortable with and that he's good at. Bob's your uncle, right? I mean, the idea that he could have, that he's happy doing what he's doing, and he finds something that he is good at. That's the point, right? That he has skills and he finds his way.
It's so true, Trudy. Okay, so we're running out of time here, but we're gonna go quickly through this case of Joey. So this was a case written in. Joey is an 8-year-old with autism, OCD, developmental delay, seizures, and pica. His parents are separated, and he's going back and forth between the homes. He's largely nonverbal and uses a PEC system. Normally, he's described as very loving, kind, and sweet, and requires a lot of supervision, is totally dependent. The reason he's referred is for aggression, hitting, throwing things, damaging property, bolting, slapping. He's not toilet trained and can smear feces at times. Currently, he's on risperidone. He's described as easily distracted, loves the water, and loves to swim. His dad has depression, and mom has a history of celiac and diverticulitis, and he's sensitive to wheat and pollen. So, Robin, how would you approach this case? Like, what's going through your mind? And I've just pulled up the slide for you again.
Sure. So I'm going to speak for as quickly as I can, but generally, in this kind of case, I'm hearing is a happy kid. I'm not hearing any medical disorder or pain. Is there any psychosocial environmental factors? I'm primarily hearing that there's a separated family, and it could be disruptive with going back and forth. The question that this person who sent in the history didn't tell us is this a lifelong behavior? I'm assuming it is. If that's the case, then the question is, does he have ADHD?
Mm-hmm.
And Ainsley and myself have talked about ADHD and autism and intellectual disability, and how they have symptoms that occur in all the same conditions. And it's really quite difficult sometimes to make a decision as to whether someone does have ADHD. Assuming he does have ADHD, you probably want to treat it,
Mm-hmm.
because it can make a huge difference to this kid's life. And we generally, in these kind of kids, use a medication called clonidine. I'd first want to make sure the kid is sleeping,
Mm-hmm.
because sleep problems sometimes are the first thing to treat in kids like this. The person sending in the question didn't mention sleep, but that's where I'd be. I'm going to leave it to Ainsley to comment on some of the other factors and developmental issues.
Yeah, so I know we just have a couple minutes, so I'm just going to be brief, but I would, just to throw it out there, I would question the OCD diagnosis. Often OCD is misdiagnosed in kids with autism, and really it's just a repetitive behavior or a ritual where they line things up, a stereotypy. The big way to know the difference is if they like it, it tends to be an autism repetitive behavior. If they don't like it, then it tends to be OCD, just as a general rule of thumb. I know the big question was around the presenting issue was around the aggression. With those kinds of cases, I really like to help parents find out what is the most, what is the aggression look like, and what is the most specific impairing aggressive problem. So let's define it, let's track it, and let's do something called the functional behavioral analysis to understand the function of the behavior and not try to treat all of the behaviors at once. And then I'm curious about the PICA as well, and trying to understand that behavior. Sometimes there can be some workup that can be done to understand that. Sometimes there can be some safety concerns. So it's something else that I have on my radar.
Hey.
Yeah, thanks, Ainsley. I guess we're running, but the PICA is important because PICA can be a sign of iron deficiency.
Yeah.
And iron deficiency can cause sleep disturbances and ADHD-like behaviors. It can also be developmentally consistent with a child with a very, middle age of under 2 as well.
Okay, well, thank you. So our team just had a few clinical pearls to wrap this up, summarizing the whole 3 series. So the first is beware of diagnostic overshadowing. Make sure you treat what is treatable. Intensive early intervention has evidence before age 6, but afterwards, look for psychiatric comorbidities. The parent is the child's best advocate, and we need to use them to make sure that we're providing the most support for the child and the family. As things change, treatment needs to change, and this is a lifelong condition, and we need to adapt as the child grows and goes through the normal stages of development. It can be really hard to find the right treatment, so we have to be really sensitive to parents and help them navigate the system. And we need to pick what's important. We need to triage with the children and family as to what the important things are and focus on those. So I think we'll end there. Lisa, I'm not sure we have time for questions. How are we doing?
Yeah, I think we're right at the end of our time here. Thank you so much. You did answer a tremendous number of questions, and I just want to remind everybody that this session has been recorded and everybody will be able to access just remind everybody that we are here every Wednesday and we have a great lineup in September. Please subscribe to our newsletter to get that information and go to our website. Thank you so much, Jennifer, Ainsley, Trudy, and Robin. This has been fantastic. And we will forward any other questions we have for your team. some people were looking for the diagnostic tools, the ADOS, so I don't know if there's a way to share that sort of information, but we can connect on that after and try to get that up on the website as well, or direct people where they can learn more about the diagnostic tools. So
Great, thank you.
Thanks everybody. Have a great week.